So, if you've been listening to this podcast for a while, you've probably heard the topic person centered care more than once, and it's one we think is hugely important. But how is this different than how we were taught in school? What needs to change in healthcare to help this become the default mode of interacting with patients? This week, we're going to talk with Carla Rossio, a physical therapist and PhD student who's studying this very topic. We discuss her views on person-centered care, and she shares some tips for early career clinicians on how they can apply person-centered care in their practice. Carla shares some great resources and tips around person-centered care, and I think you're going to find some significant value. Enjoy the episode.
This is the Modern Pain Podcast with Mark Carla.
Welcome to the podcast, Carla.
Hi, Mark. Thank you very much. Thank you so much for having me.
Yeah, I've been able to kind of interact with you a little bit online and through social media, the wonderful world we live in, where you can interact with people from Trinidad who are,
Indeed.
you would never have had these opportunities prior to the old social media days. But
That's so true.
So some of the nice things about social media these days, because obviously there can be some frustrating parts of it as well. But for those in the audience who aren't aware of you, Carla, do you mind introducing yourself a little bit and letting folks know where you're at and what you're up to?
Sure. I am, my name's Carla Rossio, and I actually live in Trinidad. I practice in Trinidad, but I've been trained in the US, and I've been practicing here in Trinidad for about 18 years in primarily outpatient orthopedic care. I also do some work inpatient and ICU care, on a contract basis. But right now I am pursuing my PhD, and my PhD is focused on person-centered care and the role of patient preferences in patient-centered care, person-centered care, situated in the whole system of value-based care.
And of course, as you hear her talk about that, you see why we wanted to talk to Carla, because person-centered care is a big thing that we like to discuss and push, just because it's a way of kind of working with people, and that puts them front and center instead of some of the ways traditionally. And as I was reading your website and some of your bio and different things leading into the episode, it's always interesting when I talk to folks who are in similar mindsets, because we often share similar journeys as far as the struggles that we've had as we've kind of come up in the biomedical model. Of course, it has its place, but could you kind of just give folks a little bit of like your journey with that, as far as maybe what you were taught in school, and how did it lead you to like this person-centered care kind of push and approach for yourself?
Yes, of course, we were all taught, the whole biomechanical model. And let's frame this in the context of back pain, the ubiquitous back pain. So, I was trained and did lots and lots of courses, fantastic courses, on core stability and the neuromuscular training and everything. And being in a private outpatient orthopedics, we see a ton of back pain, and the whole narrative about, you must engage your cause, you go about your daily activities, you lift in a certain way, you bend in a certain way, ergonomics, it's, the whole posture thing, it never sat right with me. And I guess in retrospect, it made sense at the time, it made my biomechanical sense, but as I look back, I never fully bought into it, because who walks around like a robot all day long? Who walks around in perfect posture? And I found myself telling patients things that I was not doing. And I was not walking around in perfect posture all day long. I was not engaging my core. I was bending in all different parts. And it never sat well with me. And I just thought, why are we training? Why are we telling patients to do this when we ourselves are not doing it? We're poor examples of what we preach. Anyway, I continued along the journey, and there were two events really that struck home for me that kind of made me start rethinking the whole thing. And the first one was pretty nondescript, really. I had gone to a physician's visit. It was for a mammogram, and I had never done one before. And I sat there a little nervous, a little, uncertain about what the process would be. And I saw a pamphlet in the office, and it said what to expect on your first visit. And I just was immediately, I had my anxieties appeased and everything. And I thought, what a lovely thing to do. I feel so much better. And I started implementing that in my own clinic, what to expect on your first visit, discussions of pain and that kind of thing. But the main event really that happened after that was a patient who came to me after having spinal surgery, for the typical sciatica and nerve compression. She just wasn't getting better. And I tried everything I could. We did all our core work, all our postural stuff, everything, and it just was not helping, to the point where it started affecting her emotionally. And I thought to myself, well, maybe she needs some emotional support. So we did a referral to a psychologist. And of course, everybody works in silos in the in the biomedical model sometimes. And the psychologist did her thing, and then I did my thing, and nothing helped, nothing. And I said, and the patient continued to come back. She continued to come back, and I was just wondering, we're not making a difference here. Why is she coming back? And I just felt the need to explore more. I had to help this person, and there was a sort of a drive in me. She placed so much trust in us in the clinic, and her motivation to get better was so much that I was really obligated to try to do something to help her. And so I went into the literature and I started exploring, and I came across graded motor imagery from Lorimer Mosley's group. And I started exploring that with her. And of course, you go down your rabbit holes, and it just opened up this whole incredible world of pain science, which led me then to the offshoots of not just the biomedical science per se, but the whole interpersonal, um, uh, the whole interpersonal. What's the word I'm looking for? Aspects, I guess,
Mm-hmm.
of care, and I just continue to follow the literature there, and to read and explore, and really here I am today. And it's actually because of that patient that I'm doing my PhD and in the topic that I'm doing it in. So that's a long-winded version of my journey.
No, sure. I mean, it's great to hear. I think that's definitely a common, story,
Yeah.
as far as like the people that we're staring at in front of our face, that are the people we're, privileged to serve. And we just, I can't buy what I'm selling to these patients about core stability and, like you
Yeah.
mentioned, posture and all these things that nobody does in their normal life when they're not in
No.
pain. But we ascribe all these rules. And again, they were meant in good faith for,
Yes.
at the time when we were really looking at humans very much peripherally
Mm-hmm.
through their tissues. So it had to be some, tissue-based biomechanical explanation for what's going on. And as you mentioned, pain science has just opened up a whole new world of understanding that, hey, we need to travel up the spinal cord and the brain and into the world of the
Yeah.
patients that they live in, their unique perspectives, their unique beliefs, their unique behaviors, and start to understand people more deeply from that. And I think it's interesting you talk about some of that siloed care you've seen with
Oh,
the
yeah.
psychologist or psychiatrist living in their little silo, and the physio working in their little silo, and it's still maybe not working when it's disjointed, even though that's
Very much so.
technically,
Yeah.
we're working on the mind and body, but
Mm-hmm.
when it's not integrated, it doesn't maybe, work as well as we'd like to. Um, person-centered care for folks, that's obviously, a big push that we
Mm-hmm.
speak of. I'm just curious, how do you view person-centered care? Like, what would you, if you're, I know that's a big question as far as like, and I know your probably PhD is focused a bit about this, but how do you visualize person-centered care? Like, how would you kind of, if you could like have
Mm-hmm.
a clinic that is enacting person-centered care the way that you would, and you may be doing bunch of this, I'm sure you are. How does that look compared to maybe traditional clinical kind of practice?
Wow, yeah. How do I? That's a great question, Mark. How do I envision a person-centered clinic? Um, well, I think person-centered care. It's this fuzzy topic, and there's so many definitions or operationalizations. Of course, we love to measure things in science, so we operationalize everything. But it's person-centered care. How I'm not sure we can effectively operationalize it. And for me, it is more of a way of being. Um, it's almost like it's an ecology, uh, so that I think there are a couple of researchers who have really described it, that really hit home for me. And one is Entwistle's group. They talk about a capabilities approach. Um, and they're different types of capabilities. One is you have functional capabilities, which I made some notes here, so I may look down every so often. But like functionings, those are the ways of doing things. So walking the dog is a functioning. Um, Developing a plan of care for a patient is a functioning. Something like being literate. That's a functioning. It's a way of being or a way of doing. But capabilities, sort of characteristics or opportunities that we have to allow certain functionings. So, you know, when we think, and I'll come back to this a little bit, when we think of person-centered care, it begs the question: what does it mean to treat someone as a person? So we have to understand what a person is, and I think the capabilities approach puts a nice perspective on it. So a person has certain capabilities. So capabilities for um, things like the capability to suffer, right? Things like abilities to reason, to feel, to uh, to initiate action, or to understand or participate in a social group. So these are things that are unique to someone's person. And the idea of person-centered care is that we support persons' capabilities, or so that we can then allow them certain functionings that they value. Yes. So if I were to use an example here, um, of decision making. Let's look at shared decision making, because we know shared decision making is a big thing in person centered care. There are many people who may not uh, be able to engage effectively in shared decision making, and I think a lot of the patient centered care, person centered care focuses a lot on autonomy, and the whole consumerist model of that is that you make your decisions, you are the one making the decisions. But there's some patients who may not have the capabilities to make independent decisions, and they therefore require support from, as social beings, they require support from their relations, so their families, their healthcare providers, right? So, as in the context of person-centered care in the clinic, so to come back to your question there, in a situation where a patient does not necessarily is not able to independently make these decisions on, we support their capabilities, so that we therefore, as in that clinical encounter, uh, we explain the pros and the cons of the intervention, or we look at their social situation. Can you do this? So I can give you an example where we look at the capabilities of that individual and therefore support those capabilities. So it was during COVID, I was treating a Muslim lady, and she came in, and of course, schools in Trinidad, we had a full shutdown during COVID, and so she was homeschooling her daughter, and she was in seeing me for a knee injury, and I had recommended, come and see me, come into the clinic twice a week, let's work together. And I had noticed that she was only coming once a week, so when I had asked her about it, she basically told me, she said, look, I'm a single mother. I have, and I think it was during the month of Ramadan, so she was also fasting. So I'm fasting. My daughter is with me. She's also fasting, and I have to homeschool her. I cannot come twice a week. So basically, we restructured her entire program to allow her to do whatever she can, and then rearranged her whole home exercise program and to allow her to engage in her own home exercises with the equipment or the limited equipment she had at home. So that was supporting her capabilities as, a single mom who's fasting during the month of Ramadan and, can only come to the clinic once a week. So when she did come, we just did progressions and troubleshooting if she was having any problems. And she was successfully discharged after 6 weeks. So, that's just an example of how maybe person-centered care can look in the clinic. And
Yeah.
then, yes, an example of supporting a patient's capabilities. Because we have to remember patients are social beings situated in an environment. Because remember, it's an ecology. I like to think of it as an ecology, an ecological approach to
Mhm.
care. So, we do need to understand the whole situation of that patient. And another researcher who's also done some great work is Stillwell and his colleagues. And they talk about an activism and the whole idea of that patient being situated in a world, again, that sort of ecological approach where, they have beliefs, they have feelings, they are persons who relate in to other people and with their environment. So that, they embody their beliefs, they embody their relations, and engage and react to an environment in which they are part of. So there is this whole sort of, I guess, it's a relational uh, ontology for sort of what you will.
Yeah, no, we've had Peter speak to us and
Yes,
his
yeah.
colleague in our one of our master classes when we were still doing some of the master classes at Modern Pain Care. But really enjoy his work, and definitely we'll link some of the Ann Tressel's work as well in the show notes, so you guys can check out some of those articles and kind of brush up a little bit on your person-centered care and your activism. I like how you talk about how the knowledge of the patient sits in a social context. They're social beings. And really trying to fit yourself to that unique person's, situated knowledge and where they're at in the world and how they view the world and all these different things. Where, traditionally it's like, patients come to our clinics. I know I'm just speaking for myself, but may resonate with yourself, where we try to fit the patient to us. Like, where
Yeah.
this is the clinic, this is how we do it. We do it 2 times a week for 4 weeks, and that's just how it happens. And you nicely point out a nice scenario where you were able to fit it to somebody who's got unique challenges, homeschooling, fasting, doing different
Yes.
things, where your care was adapted. I think sometimes as clinicians, I just think sometimes we're so worried and like we're worried that if our way isn't followed, it's going to be. But if you can just let go of that clinical, I don't know, maybe clinical ego or whatever, that you can just, it's all about the person you're serving and fitting yourself to them versus, vice versa, where, you're just really clinician centered practice where it's all about your way and they need to do what you say all times, and you're not really bending to the unique challenges that each person faces. I'm just curious, when we talk about social beings and we talk about where some of the knowledge these patients have sits in their unique social world and culture, and I love how you talk about ecology, because there's some, that whole topic brings up some amazing thoughts as far as things we can delve deeper into with patients and think deeper than just the traditional tissue deep way of looking at people. I'm just curious, like culturally, obviously you've seen things in the US, having went to school here, and then you've practiced in Trinidad. Are there unique cultural things that you see that exist in Trinidad that maybe don't exist in the US, or is it pretty similar? I mean, obviously there's different social worlds that sit in Trinidad versus the US. I'm just curious what your view's been as you've kind of been able to learn about person-centered care and some of that unique ecological kind of social world perspective.
Yes, we when COVID hit, we had tried telehealth because at the time, telehealth was pretty much exploding in the developed countries. Europe and the US in particular. And so we said, fantastic. We set up a whole platform for telehealth, but the uptake was really, really, really poor. And in talking to a lot of my colleagues who attempted telehealth as well, they had the same experience. And well, Trainees, as we are called, just like that interpret. They like to see their provider. They like to be touched. They like to communicate. They like that face-to-face engagement. So that it's they do not respond. They did not respond well to options for telehealth. It could be other reasons as well that it's just something that they just haven't tried and they're not accustomed and therefore maybe not willing to explore. Or a lot too, folks will live with extended families and they may not have space in their homes for that's quiet and conducive to telehealth. So privacy may be an issue, space, and in the telehealth sessions that I did conduct, that was a problem. Family members walking in the back, and privacy is an issue and that sort of stuff. So that's one thing. They really like to be face to face, and they like time with their provider. So in the context of person-centered care, they really want to speak with you face to face. They want to explain themselves, and I imagine that is not different from anywhere else in the world. But I think that is one thing that is extremely valued by trainees here.
Sure. No, I think, I think there's definitely some folks that we see like that in the US who are very much like that person. But we do also have like this busy, society where you got to be working all, 80 hours a week and cranking away, where if I can do something where I can do it versus the internet. I'm just speaking for some of the folks that we saw that had a decent uptake on telehealth, or some of the folks who were very fearful to maybe
to come out,
to come out of the home with, all the uncertainty that was going on with COVID, especially early on. So yeah, it's interesting just to see different cultures and how they kind of, work with healthcare. But I think some more social kind of, community-based cultures, definitely it seems to be, me or what I've seen and heard from colleagues is like that whole telehealth thing just really never, took off. Folks that are very much value more their social beings and being within their communities. It wasn't really as, an interest to okay, let's just separate each other into a webcam-based interaction. Wasn't really attractive for a lot of folks in different parts of the world. So, and definitely still some folks here in the US as well. I was, as you kind of reflect back on how you've developed this kind of perspective, obviously you've done some great studies and you're probably in the top percentage of physios who've really looked deeper at things than just, the day-to-day grind of workday. Excuse me. I'm just curious, few things, within your colleagues. I know it's always different and there's always going to be different drives within our fellow professionals. I'm just, how's been the uptake and things you've seen, maybe not just in your clinical setting, immediate clinical setting, maybe general in Trinidad, and also maybe even what you've seen in your colleagues in the US from your perspective? Like, where do you see person-centered care as far as truly looking at it a little bit more big picture versus, some of the traditional ways we look at things in physio? I know there's, just speaking for myself, there's definitely, where we see folks that are just holding to old traditional models because it's a source of comfort and stability, because it can be very destabilizing for a professional when you start questioning our comfort zone clinically. I'm just curious, what's been your experience with that in your clinical world?
Yeah, it's similar there, Mark. The person-centered care, for me, it runs the gamut of the system. You can't just have it in the clinical encounter. It needs to be expanded through, into health policy and all that. So it has to be supported by the system. And I feel that oftentimes it is not. So clinics here, particularly, are still very productivity based. So it is very difficult for that one. Well, for that is a major reason why it is very difficult to engage in person-centered care, and spend time with your patient, and listen to that patient. You know, you're seeing a couple of patients at once, more than one. There's some therapists who are very highly product driven productivity wise, and you know, we'll see multiple patients at once. And I know that that's a common model for many clinics internationally as well. Um, so that's one aspect of it, the time constraints. And when you look at the research in terms of the barriers to person-centered care, time is a huge one. It's one of the top ones for physicians as well. Um, the other thing is our training. It is, and for me, I am still challenged on a daily basis, and this is one of the reasons why we need a sort of a transdisciplinary in care, really, and communication. We need to work more with psychologists who can help us with the psychological aspects of care. And I'm not saying that we become, like psychologists, we have very different roles, but certainly in the communication aspects, in how we deal with patients in distress. I think we need a lot better training. I've learned on the job by force, and with some of the decisions I've made to cut my productivity a little bit. Um, but it is extremely challenging to try to learn such a difficult skill when you have not been trained in it, when you are forced into a setting that demands productivity. So I think if we are better trained in it, it would come maybe a little bit easier to us, so that we can have that a bit better balance between productivity and person-centered care. Um, so that has implications for how we educate our PTs and now our other healthcare providers as well.
Yeah, that you actually beautifully segued into my next question as far as our training, because I think there's still this training rooted in biomechanical ways of looking at things. And I'm lucky I get to interject in our curriculum a few times. I work at a university here in the U.S. and mainly see patients, but I get to lecture, and it's usually just to at least stimulate some thoughts of realize, students, that you're learning a very black and white, clinician-centered way of looking at a person's condition, and it's much more complex than that. And we try to bring in stories. We've been fortunate to get to know Gilletta Belton, who's shared her stories and does a lot of advocacy on the patient front. We had Tom Bowen on last week. He'll be probably published by the time you're hearing this podcast. He's the podcast that was just before yours. He's another patient who's sharing his wisdom from the patient experience, because that's honestly some of the best teachers out there. I don't know what your thoughts are, but I've learned more from patients than I have learned in my university. I mean, granted, the university teaches you a lot. I'm not by any means downplaying our university education, but that knowledge sits in an academic context, and the knowledge, how does that knowledge sit in a clinical encounter, and how do we make it work with the world of a human in front of us? And it doesn't always, definitely, I'd say rarely, maybe 10, 20% is it that black and white biomechanical classic case of X, Y, or Z that you learn in school. It's a lot more complex than that. And complexity is something that's hard for students to deal with, just because we're just trying to grasp for some stability of our knowledge to be able to function in a clinic. I'm just curious if you were able to, take over physio training and really put it in a way that you think would position us as physios. And maybe this is not just physios, this is probably all healthcare folks, but what do you think would need to happen to, what maybe subjects are missing, or what do we need to do? I know you've mentioned some transdisciplinary stuff, which I fully agree. I don't think we need to learn in silos. We need to learn alongside each other.
That's
as we're seeing humans with these supposedly siloed conditions, how they all interrelate, so people can open their eyes like, gosh, this is this my DO physician sees it this way. I see it this way as a physio. The psychologist seeing it this way, and it's all the same person. It's all that same ecosystem that person's dealing with. But I'm curious what your thoughts would be on, like, what would be the changes you'd love to see in education to help push this along a little bit more quickly, so people are getting this coming out of school.
Yeah. In PT education, I have this thing where, you bring the clinic into the classroom. In everything you do, like you don't have to, uh, you don't have to teach diagnoses like clinical pathology in that sort of vacuum. You teach it with relevance to the real life patient. Uh, and yeah, and I think the bringing the patient stories in and using and challenging the students to think and put themselves in the shoes of a patient with diabetes. How can we bring the life world of when we're learning about diabetes, for instance, in clinical pathology, whatever. Uh, how can we bring that patient who lives with diabetes into that context of learning about diabetes? What else do the patient the students have to think about as opposed to insulin management and diabetic foot ulcers and that kind of thing? So what else? So as instead of just looking at it from a purely pathological perspective, we look at it also from a social perspective. We look at it from a psychological perspective as well, so that they start to think about the ramifications that maybe diagnoses have for patients in their lives, and therefore how can we as healthcare providers interject and help them live a better life? How can we sort of uh, uh, what's the word I'm looking for? How can we sort of cultivate their capabilities so that they can live a life where they're able to engage in their valued functionings? So I think the more critical thinking, more storytelling, and I think more problem solving from an earlier stage. And I know that the students are maybe overwhelmed a little bit because they're learning so much, and they have no clinical experience and no way to situate the knowledge that they're learning, the knowledge about pathology that they're learning. But I think that we can help them situate that knowledge in the life of a patient better in the clinic, in the classroom.
Yeah, no, I would agree. I think bringing those patient stories and unique, humans to bring those conditions to life, because I think sometimes we
Yes,
see them
bring
in
the conditions to
this
life.
this sterile textbook
Hmm.
PowerPoint environment, which is not what you see clinically. I mean, the people that come in with that condition have families, have friends, have
Yep.
workplaces, have social pressures, have psychological challenges, we all have that stuff. I mean, but
Hmm.
it's, especially as researchers, so much pointed to the fact that these things often drive outcomes more than how well their lumbopelvic rhythm is, or
That's right.
how
Yeah.
how well they are compliant with certain maybe diabetic foot care things. I mean, obviously there's some benefits to that stuff. We're not by any
Hmm.
means downplaying it, but it just
Correct.
it narrows somebody down to this like physical, biomedical physical being. And when we see, well, gosh, this person can access even a proper nutrition socially, in their worlds to produce an environment where healing of a diabetic ulcer or different things is. So there's a lot of big
Hmm.
picture issues that I think, it's hard to portray in a textbook. I mean, you might have a blurb. I always remember I just gravitate
Hmm.
towards the physical stuff that I thought was my domain, which, obviously we still focus a lot on, physio or in the physical part, but and that stuff's so much interconnected with our social world and our psychological world and all these things that, even though they're taught siloed, I think we need to start teaching them in that much more transdisciplinary mode that you spoke of. So I definitely agree with you there. So I'm just curious too, as we one, I'd like to hear like what's like your work looking like. I know with your PhD, there's probably some dissertation work that's going to happen with that, and I'm just curious if you could share like what you're looking to be studying, and when it comes to person centered care, like maybe what that looks like for you, and then any other things you would recommend to aspiring physios. Maybe they're in school or maybe they're in early careers and dealing with some of the struggles that you and I both have when we're trying to rectify this knowledge that was so situated nicely in a classroom, and we can put it on an exam sheet and get a score and do well, but that doesn't always fit well with the challenging world of the clinic, where it's not as nearly black and white. But first, I'd love to hear what you're up to in your studying and your research.
Well, what I'm doing, I'm in the early phases. I'm getting my IRB approval and everything set up right now. My hope is to look at patient preferences for attributes of patient-centered care and compare those preferences to those of physicians, in the sense of what aspects of person-centered care do physicians think their patients want. So I'm looking at concordance between the two in Trinidad. So because patients may value, and we know from some of the literature that providers often do not know what their patients want. So I'm looking at the concordance between the two in the context of chronic low back pain in Trinidad. So I'm using a fairly new research method. It's pretty new to physical therapy. It's a discrete choice experiment. It comes from economics, and it is a way to look at how patients value a particular attribute or characteristic. So it will offer an understanding of how patients make trade-offs, for instance. So I'm going to put a cost attribute in there and ask them basically to choose different scenarios, between different scenarios. And it would be, would you prefer that, or would you be able, I would be able to understand what patients are willing to pay more for, what attributes patients are willing to pay more for. So it may be that they would pay more money to see a therapist who engages them in decision making, or they may pay more money to see a therapist who works in an integrated care system. So it's looking at what they value and how they would make trade-offs in terms of attributes of person-centered care. So yeah, so that's what I am hoping to pursue there.
Sure. Last question I have for you, Carla, and we would greatly appreciate your time. Is just like, if you could just like give some advice to like some of the early career clinicians who are kind of struggling to come to terms with this lack of the fitting of this knowledge that's situated nicely in an academic setting, but is struggling to situate itself well in a clinical setting. And maybe even some DPT students who are kind of questioning what they're learning and seeing maybe some of the discussions on social media of how it's kind of limited. I'm just curious what advice you'd have to some of those younger career clinicians or students who are struggling to kind of see where this all fits.
Yeah, so I think the biggest, the most important advice I have, at least for me, would be to respect the different types of knowledge that there are. Our knowledge as physios, our biomedical knowledge is valuable, yes, absolutely. But the patients also come with their own knowledge. There are other types of knowledge, as opposed to that sort of positivist, empirical type knowledge that we are trained in. So, patients are experts in their own right. They are experts in living with their condition, and we need to respect that. And we need to validate their experiences as humans who have the capabilities to suffer. I think it's best summed up by Andrew Miles. Has this wonderful quote. He's a philosopher and is doing a lot of work on person-centered care. And I have it written down here. And he says, medicine's wide variety of knowledge sources should be able to form holistic webs in order to build and respond to a clinical picture or tapestry. So the idea is that all kinds of knowledge must come together to form this picture of the patient, or this tapestry, and he talks about the patient as being not just a picture of someone ill in bed, but it's more of he describes it. I love his descriptions as an impressionist painting. of someone, of the patient surrounded by their home, their family, that they're in, it's situated inside their environment. And this has, and this reflects Stilwell's work, the whole of an activism, and the whole idea that a patient is embedded and an embodied being, so that we really need to respect all different types of knowledge and use all that knowledge, from the patient perspective, from our knowledge that we were trained in, to create a sort of a holistic picture of the patient, so that we can, determine the best plan of care and really cultivate that patient's capabilities so that they can engage in the activities that they value and live a productive life.
No, I love that quote. That is a great quote, and I think definitely hits home for what we're talking about as far as those different tapestries and looking at different forms of knowledge. And I think sometimes just you don't implicitly or understand how implicitly we operate as healthcare people of the knowledge we consider knowledge. And it's our knowledge, the knowledge that we learn, that we situate into the clinic, that we sometimes disregard that expert that sits beside you, which is the patient, who knows their life, who knows their social world, who knows their own psychology, the way they look and perceive and respond to the world and the experiences they're in. So I definitely wholeheartedly agree. I think that is a great way to look at what we're up to. I want to respect your time today, Carla, and any, where could folks kind of find you online if they wanted to kind of follow what you're up to in your work, whether it be social media or maybe a website?
Yeah, I am pretty active. I haven't been for the last month just because of stuff with the PhD, but on LinkedIn, very, very active usually. You can also find me on Twitter at, I can give you my Twitter handle, CMRausio23. It's not an easy Twitter handle to remember, but you can find me there as well. And on Instagram as Person-Centered PT.
Yeah, no, we'll definitely.
But I'm most active on LinkedIn.
Yeah, that's where our conversations have happened. So yeah, definitely great.
On my website.
Sure, yeah, and we'll link all that stuff in the show notes so folks can kind of check that out. But definitely a good follow on social media. Carla's having some great discussions out there, and she's doing some great work. I think obviously with our discussions today, you can hear how she's leading some of the thoughts as far as pushing this into the clinic. So we need more Carlas out there in the world and more people to kind of listen to what you're up to. And I look forward to seeing your work. I wish you great luck on your PhD and your dissertation. I know that is a massive undertaking and a lot of work, but wish you the best of luck on it.
Thank you so much, Mark. I really appreciate this, and thank you so much for having me.
Absolutely, and hopefully we'll have you back in the future as we hear how your PhD progresses. But
That'd be great.
Absolutely. So really appreciate you listening this week, and we will talk to you all next week.